Welcome to the recorded version of the Case for Palliative Care for People with IDD and Dementia from April 18th, 2018, part of the National Alzheimer's and Dementia Resource Center webinar series sponsored by the Administration for Community Living.
Thanks so much, Steve. Welcome again, everyone, to the webinar today. We're happy to have you. In this webinar series, the Administration for Community Living's National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging. We're pleased to have all of you in attendance today. And before we start, Erin Long of the Administration for Community Living will provide a brief welcome.
Hi, everyone. I want to thank you for taking the time out of your busy day to join us for this very important webinar. I want to thank Mary Hogan and Phil McCallion for taking the time out of their busy day to share their wisdom with you. We're super excited to learn much more about this very important topic. And with that, I will give it back to you, Sari.
Thanks, Erin. For today's webinar, you just heard, we will hear from Mary Hogan and Phil McCallion. Mary Hogan's a member of the National Task Group, or NTG, on Intellectual Disabilities and Dementia Practices Steering Committee. She also was a contributing author to Aging and Down Syndrome, a Health and Wellbeing Guidebook, and its companion publication, Alzheimer's Disease and Down Syndrome, a Practical Guidebook for Caregivers. Phil McCallion is director and professor at Temple University's School of Social Work. He's also a consultant on intellectual and developmental disabilities and dementia to the National Alzheimer's and Dementia Resource Center. He is also a member with Mary of the NTG Steering Committee. I'm going to turn things over to Mary to begin the presentation, and then we will hear from Phil. So take it away, Mary.
Okay, thank you very much. I'm happy to be here, and I'm really pleased to be presenting with Phil today. And a discussion of palliative care for people with IDD is really long overdue. And for the purpose of today's webinar, this first slide describes the two populations, and I will let you review this at your leisure at the end of the presentation, but we thought it was helpful for you to be able to differentiate between the two groups of people that we might be referring to. My job today is to take a few minutes to step back and look at some of the challenges and the obstacles that people with IDD experience before, during, and after a diagnosis of Alzheimer's disease or other dementia. And hopefully this discussion will help reinforce the need for palliative care. Let's see here. I think that it's going to be helpful to put in perspective some of the challenges that people with IDD face. And the one that comes to mind for me is the fact that people with IDD are living longer. Case in point today is people with Down syndrome have an average life expectancy of about 60. But despite increased life expectancy, people with intellectual disabilities and developmental disabilities face many care disparities that impact their quality of life and their health care outcomes. And I'm sure that the audience can list some disparities on their own, but the few that I'll mention is that there is really a lack of provider knowledge and limited access to quality health care and health care promotion programs. And there's difficulties with communication, and that's very obvious in some settings. And there's not always enough time to allow the person to communicate their needs. And there are challenges transitioning from one care provider to another. There are a lot of attitudinal barriers, and there are certainly poorer outcomes in acute care. I just wanted to point out that the logo on this page was produced by Beth, who was a young woman with Down syndrome, who was a great artist, a really active young woman in her community, lived with her brothers, and eventually moved into a small group home as her Alzheimer's disease progressed. And that's Richard, who lived with his mom and dad, who were aging parents who took care of Richard until the end of the last 4 years of his life. There are really frequently multiple co-occurring conditions for people with intellectual disabilities and developmental disabilities, which really translates into complex health conditions as people age. For example, folks with Down syndrome have accelerated aging, sensory losses, depression, sleep apnea, osteoporosis, osteoarthritis, and as you well know, they're at higher risk for the development of early onset of Alzheimer's disease. And complex care needs become really much more problematic in the presence of healthcare disparities. And individuals with IDD often experience chronic conditions that are frequently poorly managed. And these chronic conditions really require a team of providers with in-depth knowledge of all of their co-occurring conditions, and a team that's really dedicated to coordinated care. But the reality is that without strong advocacy in conjunction with a lot of collaborative efforts, care is often compromised for people with IDD long before a possible diagnosis of Alzheimer's disease or other dementia. And this is Joel. He, too, enjoyed a really rich life. He lived in a group home for a really long time, had the same roommate. And as they aged, each of them developed a variety of health care conditions that required specialization, and they eventually had to be separated and moved into separate group homes, ICFs, where they spent the remainder of their lives with challenges related to Alzheimer's disease. Joel was a character, and he had a full and rich life. I think that what we fail to realize is at times that diagnosing Alzheimer's disease or related dementia is really a formidable task, and people are obviously often able to self-report their changes in memory and thinking, and it's obviously those around them that usually note the changes. And when changes do occur, many individuals with IDD don't have access to a thorough evaluation, and there's very often a presumptive approach to making a diagnosis of dementia. In an article published at the Mayo Clinic Proceedings by Dr. Julie Moran and colleagues from the NTG, they outlined a systematic approach to aid in reaching a differential diagnosis of dementia for this population. The title's a mouthful. It's called the NTG Consensus Recommendations for the Evaluation and Management of Dementia in Adults with Intellectual Difficulties. It's a fine article, and I would recommend that nurses and agencies become familiar with the contents and family members become familiar with the contents, because the outlined evaluation is extremely comprehensive and includes medical, psychiatric, family, and social histories, baseline functioning compared to current functioning compared to a historical functioning basis. And I think Dr. Moran and her colleagues are really emphasizing the fact that just because a person has an intellectual disability doesn't mean that they shouldn't have the same kind of in-depth differential diagnosis as the members of the general population have as well. After a complete examination and the investigation of psychosocial changes, there is also recommended a cognitive assessment, which obviously would use instruments specialized for this population rather than those used with the general population. So what happens after this evaluation? And Dr. Moran and her colleagues really emphasized the importance of synthesizing all of the information which can lead to a diagnosis of dementia or to the potential resolution of a treatable condition that would rule out the possibility of dementia. But this information can also help shape future care, especially with the presence of a diagnosis. But after a diagnosis of dementia, we always ask, what's next? And as healthcare disparities and chronic conditions and very complex issues related to diagnostic overshadowing, they all warrant special attention, and I think that the special attention may be what we might be able to help address through palliative care. So one option, as I said, is in the early stages of Alzheimer's disease or other dementia, the World Health Organization recognizes that Alzheimer's disease is a life-limiting illness and has stated that every person with a progressive illness has a right to palliative care. So they've recognized that palliative care and dementia care are both person-centered and relationship-centered, and that they conclude that palliative care is applicable early in the course of the disease. For the WHO, good dementia care includes access to palliative care, and I think we really need to include that in our mindset when we're thinking about the kind of care that we're hoping to be able to provide to our family and community members. As Phil will attest to, there's a lot of information from the UK, Ireland, and Europe that suggests the palliative care approach to dementia care should really occur from diagnosis onward. And that would help prevent unnecessary suffering and pain and enhance symptom management. I think folks are better informed about decision-making with that kind of a support network. I think they can address spiritual and social aspects of care. And overall, our goal is to improve the quality of life for people with dementia and their families. And in the U.S., there's something called the Dementia Work Group, which representatives from a variety of academies, like AMA, the Psychiatric Association, came together to develop a national plan to improve dementia care. And it included the suggestion that palliative care concepts be used to guide care long before the advanced stages of the disease. In their recommendation, there is really no specific reference to people with intellectual disabilities. However, there is a group called the National Consensus Project for Quality Palliative Care, and those are specialists in quality palliative care. They're nurses, they're social workers, and other healthcare providers. They've published a clinical guideline for palliative care. And in their guidelines, they do include people with IDD in their list of populations to be served if diagnosed with a serious illness. And their guidelines focus on 8 domains, and they include quality measures that are really important because it helps us determine whether we're having an impact on patient and family experience, and whether we really do have better quality of care, and if we're making better use of our health care resources. So let's see. Going on here. ICF. I see a little note from Sari saying ICF. And ICF is an intermediate care facility, and that's for people that are more fragile in the DD system that may be moving from one setting to another setting. And I did refer to that as it's really hard for me to provide the presentation and look at the questions too. So sorry. I will do the best to kind of address that. But an ICF is an intermediate care facility, and folks with who are more medically fragile may end up in that setting over the course of their lifetime. I think there's one really important thing for us to be considering here as part of the paradigm that we might consider as a reason for palliative care for folks with intellectual disabilities. People with ID are really at a high risk for diagnostic overshadowing, and there is a definition of that here in front of you, and I think plain and simple is once a diagnosis of Alzheimer's disease is made, it's not uncommon for every behavioral manifestation to be explained as an issue related to Alzheimer's disease, rather than doing an investigative process that would help rule out the possibility that this is related to either a co-occurring condition or a new condition that then is left untreated. So folks with IDD and dementia have historically had problems reporting pain, and as the disease progresses, those who could report may no longer be able to do so. So pain assessment becomes a really important part of palliative care, and I think it really offers the opportunity for reducing the risk of suffering for people with intellectual disabilities. I do know that from a personal experience with a family member, behaviors that were associated with screaming out when the person was being dressed were all attributed to Alzheimer's changes, when in fact they were really related to fractures because the person had severe osteoporosis. So, and I think that it left the individual suffering for a really long time before we were able to determine what indeed was occurring for the individual. So without informed advocates and invested dementia palliative care team, it's not unusual for these pre-existing conditions to be overlooked. And I think comfort and relief from distress isn't really consistently available, putting the person really at greater risk for behavior and psychiatric symptoms of dementia. With good dementia care, diagnostic overshadowing may be greatly reduced, and I think it offers the opportunity for lots of suffering to be eliminated. The thing that I would like to say is that we know little or nothing about the sense of loss that people, the psychic loss that people might experience with IDD, with dementia. And we know little about their spiritual life, and I don't think we can assume that they do not have a rich inner life as well. So when we look at palliative care, I think it's also an opportunity to step back and look at the kinds of things that the person enjoyed in their life prior to the onset of this disease. But I think that if we arm ourselves with knowledge, I think advocates can begin to the process of connecting with the ID community, with palliative care providers. And no doubt, and Phil will address this later, that training will be required across both settings to facilitate this implementation. And I think that this is one of the most important slides for me, because I think that we overlook the fact that people with IDD really deserve the right to live life fully to the end of life. And I think we should ask ourselves, have we translated palliative care into practice for individuals with IDD here? And I think in some places we have, in some places we haven't. This is Sharon and her sister Robin. They live together on the West Coast. Robin has Down syndrome and was diagnosed with Alzheimer's disease several years ago. She's been deprived of her memory and has experienced the degenerative physical changes that go along with Alzheimer's disease that we often don't talk about. But Robin is fully dependent on others for 24-hour care, and Sharon is committed to finding meaning and pleasure in each day. And she provides Robin with opportunities to do the same. She's an inspiration to those around her, and she's a very creative problem solver. But Sharon has emphasized that the critical support network that she has received from palliative and hospice care has enabled her to manage the stress that that's related to caregiving, and it has enabled her to develop and maintain a really proactive care plan for Robin that keeps Robin safe and free of invasive procedures that might otherwise be initiated. So moments of terror and self-doubt for Sharon when in a crisis are really offset by the support and the presence and the calm reassurance from the care team she has access to. I'm sorry on this slide that I don't have a picture of Nadu, and I have corresponded with Nadu's mom for a couple of years, and she was willing to share their journey. Nadu was an only child who had Down syndrome, and she had a very active life marked by an independent spirit, was really creative, had strong community connections. And she began her decline with Alzheimer's disease in her late 30s with subtle changes that her mom noted and attributed to accelerated aging. Nadu began to experience frequent seizures and eventually became bedbound and confined to her home with her mom. Her mom was a widow. Marlise's first request for palliative care for Nadu was actually initially denied. And after some hospitalizations for pneumonia, a fall caused by seizures, and a subsequent brain bleed, the request for palliative care was granted. And the team, including nurses, therapists, and social workers, became engaged in Nadu's care. And Marlise reports that the care provided was palliative for both Nadu and herself. And it eased her burden, it provided comfort and emotional support, and she had experienced excessive stress as she watched her daughter slowly disappear from her life. The team simplified life as they managed Nadu's medication for Marlise, and Marlise felt that their presence, their medical care, and oversight extended Nadu's life and really freed her to enjoy moments, tender moments with her daughter as she approached the end of her life. Palliative care transitioned for them into hospice care, and Nadu remained at home until the end of her life. She died in October 2016 of pneumonia, a common complication of Alzheimer's disease, and it's worth noting that Nadu was 48 years old. Her mom celebrated Nadu's life with her friends, and they viewed the Life Goes On segment in which Nadu and many of them were featured. And Marlise said they expressed hilarity and pleasure, and they provided Marlise great joy in that moment. And the fact of the matter is that life does go on, and with an endearing sense of loss for those of us who have lost a family member with an intellectual disability and dementia, Alzheimer's or other dementia. So I leave you with a definition of the of palliative care from the World Health Organization, and that was the definition that Phil and I had agreed to use. In the United States, Health and Human Services and CMS have a different definition of palliative care, and I can make that available for you as well. But I think what we need to do is think about the information that's provided about the purpose of palliative care, the challenges that our community members experience, and I think make a conscious effort to adopt palliative care as part of good person-centered and relationship-centered care for our family members. As I wrap this up, I wanted to say that in 2007, there was an article written by a gentleman named Dylan Harris, and the name of the article was Forget Me Not, Palliative Care for People with Dementia. And he wrote that dementia was life-limiting with complex needs, and the needs of people with dementia were poorly addressed, and their pain was untreated, and they were subjected to burdensome interventions. And at that point in time, there began to be the movement to include the general population in palliative care treatment. And I'd like to suggest today that 11 years later, we reframe the title and say, Forget Me Not, Palliative Care for People with IDD and Dementia. And I think if we work together, we can collectively see that this happens. So there is some additional information about the definition of palliative care here, breaking it down in more specific details for you. And I know that Phil will follow up on this in his discussion. So there you go.
Thanks, Mary, so much. Phil, we'll turn it over to you for the remainder of the presentation prior to questions.
Okay, thank you very much. And, a great pleasure to present with Mary, because I think so much of this is about the perspective of families of people with ID, as well as those who are working in the field and those who are doing research in the field. And in fact, much of what I'm going to present is based upon an international summit on intellectual disability and dementia that was held in October 2016. We hold these summits periodically. This time we focused upon advanced dementia, and it was very much a collection of all of those individuals and perspectives so that we could really target in on this issue. I think sometimes that for all of us there's a question about what's the same and what's different for people with intellectual disabilities and dementia, and particularly what's different for people with Down syndrome who appear to have both a greater level of dementia, but also earlier onset. We tend to talk about in the 40s and 50s. Not impossible to see it in the 30s, but not as frequent. But also that a greater number of people with Down syndrome are likely to have this disease. But we were very much looking at these issues to recognize, and you'll see here on this chart, those in red are people with Down syndrome, those in blue are people with other intellectual disabilities, and you'll see this idea of sort of a much earlier onset, but also the greater frequency of a diagnosis of dementia, particularly in the group with Down syndrome. Now, in the slides here, which are by, these are charts based on the work of Lai Williams, who looked particularly at people with Down syndrome, and Sally Ann Cooper, who looked particularly at those with other types of intellectual and developmental disabilities. In Sally Ann's data, it's still higher than we see for the general population. Some other people argue that it's about the same, but what nobody argues about is the rates of dementia in people with Down syndrome. So let's talk about that also, but then also talk about this issue of advanced dementia. In some ways, I hear some people who talk about dementia as being the great equalizer for all of us, that in advanced dementia, that we all look pretty much the same. But in terms of its definition and in terms of the understanding of advanced dementia, there are nevertheless some differences, particularly for people with Down syndrome. And one of the things that we talk about the most is late onset seizures. And it's still unclear which comes first, what the relationship is between the two. Some work that I've done with colleagues, we've been looking over 20 years at what happens for people with Down syndrome, and the two seem to occur together, but we can't really say that one causes the other. It's that they both occur together. But when you look at these characteristics of advanced dementia, and as we think about sort of recommendations for defining advanced dementia, often we utilize an instrument called the FAST, and we look at sort of these issues around declines in speech, declines in ability to do things for myself, even declines in my ability to sit up without assistance, and ultimately moving towards issues like the loss of the ability to smile and the loss of the ability to hold one's head up independently. For people with intellectual and developmental disabilities, for some, this is going to look very similar to what has been true for a large part of their lives. Not for everyone, but for some. So when we look at this issue of advanced dementia and people with intellectual and developmental disabilities, we're really looking at a change for that person from what they were able to do before, and that change for the rest of us may seem somewhat subtle, looking in from the outside, if you like, but for family members and for other caregivers, they know that this is a dramatic change. And so, you know, one of the things is really to listen to those who are providing the care, that if they say a change has happened, it really has. It's happened. So we often talk about utilizing the FAST criteria, but then also looking for other evidence that sort of the disease is advancing by looking for things like multiple hospitalizations, looking at recurrent infections, particularly urinary tract infections, and then remembering some of the issues that Mary raised, that we can't rely upon some of the same signs and symptoms, or even in particular, we can't rely upon the person to identify what's happening for them, so that we have to be particularly vigilant for these kinds of infections, and also vigilant for aspiration pneumonia. Again, for those of you who are used to working with the general population with dementia, these are things that occur there as well. But it may be that the signs and symptoms that you're looking for may not be as obvious for a person with an intellectual or developmental disability. The other thing that really came up within the summit is that there's still so much more that we need to do to prepare for the world that Mary described, where we are providing palliative and comfort care when it's needed, when it's appropriate, when it's desired. We still need to do some work on universal practice guidelines. We need to understand that the people who are providing care in the general population, this may be a new phenomenon that is directly related to the dementia. For people with intellectual and developmental disabilities, there may be lifelong care. This may be a lifelong caregiving situation, and also that home may be different as well. That sort of that we tend to think more generally that home is about a family home, that somewhere that's more structured, that's like a group home, or as Mary described, an intermediate care facility, that we might see those, well, that's more like a hospital or a nursing home. But for the individual, that may be experienced as home as well, because they have lived there for a long time. We need to be working on more valid and reliable instruments to measure advanced dementia-related change. But at the end of the day, it is about change for that person. What has changed from what they were able to do before? And then we need practice guidelines and training to really ensure that there is quality care when people have intellectual disabilities and dementia. And really what the summit was really arguing for, that we need a much better integration between what's known within the intellectual disability service system and what's known within specialist palliative care services. that they each have their own philosophies and expertise to offer, but actually there's so much overlap. And that, but that even within that overlap, there are things for each to learn. Now, on this slide, I have information from the United States that was developed by one of the ARCs. I have a curriculum, the cover of a curriculum that was developed in Ireland, and a cover of a curriculum that was developed in the UK. We're all realizing that we're going to be more effective if we all work together more effectively. And part of that working together more effectively is providing assistance to people in intellectual disability services to better recognize symptoms of pain, constipation, fevers, and nutrition and hydration concerns. And palliative care staff are going to be more effective if they have more training in and greater sensitivity to the communication challenges that people with intellectual and developmental disabilities have, that facilitating grief and loss discussions is going to be different, and to understand some of those differences, but also to recognize that their work is not simply with the person with an intellectual and developmental disability and with their families, that many times there will be staff who have cared for someone for a very long time, and there will also be peers with intellectual disabilities as well, who may have lived with that person for a very long time. And it's not only that we must deal with or help those individuals to deal with the grief that they're experiencing, but to recognize that in both the services systems and in the world in general, that we don't always recognize that their grief is important too. The last thing that I sort of highlight on that slide is that we often talk about in palliative care about recognizing the needs and preferences of the individual as we prepare to offer comfort, as we prepare increasingly for end-of-life care too. The information on those values, on those needs, on those preferences often already exists within existing person-centered plans for the person with an intellectual or developmental disability. Person-centered care has been a huge value within ID services for a very long time. So as I think about that, and I think about preparing for decision-making as well, that it has been, and this was something that came up a lot within the summit, there's been a lack of attention to decision-making and the involvement of people with an intellectual disability in decision-making about their care as dementia progresses. And again, I have sort of some pictures up here of sort of a number of different guides that are available that, again, from different countries, that there is information out there, and that, again, that sort of person-centered care has been a long-standing interest for the intellectual disability services. So I know that the slides will be available after this. There is some other information that's going to be provided, including some websites where there's links to many of these materials. So this isn't just something that I want to talk about. This is something I want to make available, and I know that Mary feels really strongly about that as well, that the NTG and other groups have worked very hard to sort of make these materials as widely available as possible, because we really would like them to be used. Advanced planning, I think, is an area that we need to do so much more. It clearly needs to be guided by the legal and accepted practice frameworks in the jurisdictions where the person lives. There have to be protocols in place. It won't happen accidentally for people with an intellectual or developmental disability to have the same opportunities to express their desires and to have those recorded in a formal way. But there are a lot of educational materials and interventions that can support that for all of the individuals that are involved in the person's life. So the other piece, and actually this is the NTG website. I've listed here the various consensus documents that came out of the conference that I mentioned. But if you go to this website, you'll also be able to find many of the guidelines that have been produced by the different groups, including the guidelines around assessment that Mary mentioned, that Julie Moran led the development of. So this is a really, I feel, a really important website to be going to because it's constantly being updated with materials that are available. Some additional resources, and again, you'll get copies of these slides, so you'll be able to go to these links, are some workbooks that have been developed, so often supported by video resources as well, on thinking ahead, on palliative care, on end-of-life care. And the last one really represents a collaboration between both intellectual and developmental disability service providers and, in this case, the New York State ARC, and the hospice and palliative care group within New York State, and the Office for People with Developmental Disabilities. So a cross-cutting, cross-system kind of approach to training to provide palliative and end-of-life care within this population. So really want to end with saying, like, there are a lot of resources out there, but each of you, in whatever aspect of this business that you're coming from, you bring skills, you bring knowledge, including the families, and I see in sort of some of the questions that a number of family members are part of this as well. You are so important to helping all of us to better understand who your family member is when they're no longer able to speak for themselves. But we all need to sort of try to bring the voice of that person in as early as possible and as completely as possible. So I'll end there. You know, and certainly this is contact information for both of us. But again, sort of want to really emphasize the importance of this issue as we think about dementia for people with intellectual disabilities and other developmental disabilities.
Great. Thank you so much, Phil and Mary. Great presentations. We did get quite a few questions in while you were both speaking, and we'll get to those right now. I also just want to encourage folks, you can continue to enter your questions into the question and answer feature on the webinar platform as we begin talking. So Steve at ASA did send out the name of the article that Mary referenced during her talk. I know quite a few people were asking about that, so you should have received that title as you were on the webinar. Can you also, to start off, Phil, can you give the participants just a brief overview of the difference between palliative care and hospice, and then we'll continue with quite a few questions that came in specifically about palliative care.
Well, you know, I think that, and there would be lots of argument about this. You know, I think that was why, you know, as Mary mentioned, we went with the WHO definition of palliative care. I think the distinction is to recognize that when we think about end-of-life care, we're often thinking about that last 6 months of care, and yet some of the that hospice care is likely to be more focused upon those end days. But comfort care and the preparation for a quality of life as a disease such as Alzheimer's progresses means that we should be looking at these things much earlier than the last 6 months, the last year. And palliative care gives us the opportunity to both provide comfort care, but also in terms of that there may still be more active activities that are occurring as well. So it's for a much longer period, and it involves a more complex range of services because it may include some proactive services. But I think, too, I'd want to emphasize what Mary raised in terms of that it is not simply about, and equally hospice care is not simply about medical care. It's also about the psychosocial. It's also about the spiritual. It's also about all of the aspects that maintain a quality of life for the person as the disease progresses.
And I'm going to interject and just complement what Phil said here. I think that if we think of the two descriptions of hospice care and palliative care, when I did the extensive reading about the topic, I think that they all come under the umbrella of palliative care, and hospice care is a subset of palliative care. And I think, but it's the philosophy of making sure that we're providing individuals meeting their needs across domains, whether they're nearing life or whether they are enduring an illness, a very challenging illness that they may recover from. So I think the palliative care very much came out of treatment for cancer patients and has evolved into treatment for people with a whole host of diseases. But if you go back and look at Dame Cecily's definition, they are intertwined very closely, and one set leads to the other subset.
Yeah, and I just add, actually someone in the chat box put in that hospice is a service. Palliative care is an approach to care that is not limited to hospice criteria.
Right.
And I think
right.
that's a helpful addition. Thank you.
Great, thank you. We have a few questions that have come in about how do we educate guardians that might be helping people with intellectual and developmental disabilities about palliative care. How do we educate families so that it is used at the best time?
Phil, I'll take a swipe at that one. And
okay.
I think historically palliative care has been, the discussion of palliative care and hospice care have been frightening to people. I think that it was an indication of that we are nearing a transition to end of life. And I think that the more able we are to present palliative care as the intent of it is to enable the person to live life fully, as comfortably as possible, with an emphasis on reduction of pain for the person, and pain being not only physical pain, but all of the other subsets of pain as well. And I think that if we are able to communicate that successfully to people who know their family member very well and are really very much struggling with the kinds of pain that they might see the family member experiencing, that I think we're better able to have people join together in terms of trying to find an alternative to care model that would include many other people in the care system. I think people often end up alone dealing with the kinds of difficulties that this disease process brings with it. And I think if we can help people understand that this will enable them to access a greater support network. And I think many of us are seeking that. And many of us have sought the reduction of pain, very visible physical pain for a family member, when the medical community was more resistant to our insistence for help at that point in time. So I think it's a team approach to this, and I think it's as we see our family members evolving throughout the process, and we also understand the demands that we face as caregivers, I think people are more inclined to embrace the concept of palliative care.
Yeah, and I'd just add to that I think that at the end of the day, good quality palliative care is about the implementation of the person's values, needs, and preferences. Those values, needs, and preferences exist not just in one's last few years. Those are things that have developed over a lifetime, and the more that we can encourage people to, first of all, know what an individual's needs, likes, and preferences are, then the more likely it is that we are ready to implement some of these things. But I think that much of the difficulty arises when we wait until the very last moment to sort of raise this issue of, well, when is the point where we might sort of implement comfort care? I think we all struggle with that a little bit. This is not unique to people with intellectual and developmental disabilities, but it is about sort of building comfort with having that conversation before it's absolutely needed.
Great, thank you. Just a follow-up to what you've both said. Can you do you know of any tools or ways that people have used in the past to discuss the values and wishes with someone who has IDD who may be nonverbal, and how to determine if palliative care might be what they want. I apologize if there's silence because no one's had that experience, but I thought I might ask because it did come up in these questions.
Yeah. No,
and I think it's a really important question.
Yep. Yeah. Yeah. I would just add that that this is also this is a reason for adding in family. If the person is living out of home, let's say in a group home, the staff there, and the person's peers, that without expressing, without being able to verbally express what my values are, what my needs are, what are the things that represent comfort versus discomfort for me, the people who live with a person, who are with them a lot, are going to have a perspective on that. And so, perhaps it is about getting that information from the person around the individual, so that rather than, someone else, talked about things being a service versus an approach, and I think of palliative care very much as an approach, and sort of wanting to sort of build comfort, wanting the person to have as best a quality of life as we're able to support. And I think that those other people around the person can often give us good information.
And I'd like to interject there. I think that the question that I saw on the scrolling through the list that was provided was also inferred that there was not a lot of family involvement with a person that was nonverbal as well, and doctors and distant family members are making decisions. I think that also was part of it that I saw, Phil. And I just wanted to comment on the fact that people that live in group homes are really surrounded by people that care about them. Many direct support professionals are very dedicated to this population. They have formed bonds with them and are, in many cases, are more like family than biological family. And I think that it really helps us to think about those are the people that know the individual very, very well. And how do we, over time, chronicle the kinds of observations that we know about what the person values or doesn't value? When we talk about end-of-life planning, I always try to remind myself and other people that it's really not an event, but it's a process. And it's a process that perhaps in this community we need to be thinking about long before end of life as we gather information and make observations and record meaningful data about the person and their likes, their dislikes, what they can tolerate, what they can't tolerate. And I think there is a role for DSPs who are very dedicated to care to be a part of the discussion, part of a team, a palliative care team that are providing support and services for somebody.
And a DSP is a direct support professional for those who aren't familiar.
Right.
Yep.
Great, thank you.
I see a question, sorry, that I'd like to answer.
Sure,
if that's okay with you. It's number 57. And somebody said, how should we educate staff and ICFs regarding dementia? I think this is a really valuable question, and I think that it's one that I know when we were in that situation, there was not a lot of information for the folks in that setting. And I think it's really important for agencies to be proactive in providing training to individuals so that they're better able to meet the needs of the members of their community. The NTG does have a training, and this is not intended to be an advertisement, but the NTG does have a dementia-capable care training, and it does include the opportunity for DSPs to participate in a 2-day training. And I know that, like in New York State around Albany, they have recently received a grant where they'll be doing a lot of training with DSPs. And I would encourage DSPs to speak up and say this is the kind of training that we need to provide care for individuals and our residents as they age. I was very fortunate with the ICF with whom I worked. They did not have training in dementia care. And we learn together about dementia care. And I think that being able to communicate to them that my support for them and for what they were providing in terms of care for my family member was very reinforcing. I think we learned together, and I think it also helped to create a resiliency around caregiving that may not have otherwise been developed without that kind of bond, and also I think a communicated respect for what they do. But I would encourage DSPs to reach out and ask for this kind of training from their agency, because we have an aging population, and I think more and more folks will present with these kinds of challenges. And they don't have to be challenges if we better understand what we can do to meet their needs. Because the bottom line is a lot of the behaviors that people always talk about with dementia are really a vocalization of an unmet need, and how do we become better detectives in terms of finding out what people actually do need, or the discomfort they're experiencing, et cetera.
And I'll just add to that you know, I certainly recognize that often it's difficult for agencies to release direct care staff or direct support professionals for 2 days or 3 days for a training, which is often what is the amount of time that many of these trainings require. And so the National Resource Center is working with some ACL grantees, and we're looking at developing a 3R training that would be available that would you know, certainly help to orient people to the disease, and also to some of the better care practices that have really been established and are evidence-based, as a way of ensuring that the needed training gets out there. But part of the motivation of doing that is because the people who are caring for someone day to day, they are the people who both have the knowledge of what the person's needs and preferences are, and they're going to be the people who are going to be delivering it. So I think that I want to reinforce what Mary's saying in terms of they should ask for it, but we also should figure out how do we provide support to that group.
The other thing I'd like to add here is sometimes people make a transition from one setting to another setting in the midst of a diagnosis of dementia. That's a really challenging time in that person's life. And I think that it's really important for us to be able to communicate to the new caregivers what kind of a life this person had prior to the onset of dementia. And I think this whole idea of life story work is really important for us to be aware of and engaged in, because when one knows the life story of an individual, and when one understands the kinds of losses that the person has experienced, it often evokes a different kind of response from the caregiver, which allows them, again, to be more resilient, to be more engaged, to be more supportive. And I think that it's so important for us to make sure that we're communicating this rich life story that many, many people have as they develop this disease, with or without an intellectual disability. And we can't lose sight of those kinds of stories to help frame care and shape outcomes, because that is really what drives care. Good care is knowing who the person is, has been, and still is, despite the very difficult aspects of dementia.
Great,
so
thank you so much.
Really great questions.
They're great questions. And you know, I wanted to comment, there's so many folks that are giving their individual situations and how they've worked through certain issues and problems, and I wish we could read about all of them so people could learn from them. We simply don't have the time to address all of them, but we really thank you for including that information. I just want to try and address one more question about how you might incorporate the notion of palliative care into advanced planning documents, whatever is used in each of the various states, like a PULSE plan, et cetera. Has that been done to your knowledge? Is there some kind of formal documentation that can be used or format that can be used? Can one of you comment on that?
But I can comment based on, there have been several actually federally funded projects that have looked at that. I think a first step certainly would be to talk to your state's Developmental Disabilities Planning Council, because many of them, or a number of them, have funded projects around the development of materials to support that. Certainly, I'm most familiar with what happened in New York, but I know a number of other states where that's occurred. The other one that jumps to mind actually as well is New Jersey, that their Developmental Disabilities Planning Council and their Center for Excellence did some work. And what I've always liked about the Developmental Disabilities Planning Councils is that they provide their materials to everybody for free. So it's a great place to start, and then through them perhaps to reach out to other councils that may have some materials. Refer you again to the NTG website. There's a lot of really good materials up there as well. And there are also some materials from other countries, but again, you can probably access those most easily through groups like the NTG. I know that the National ARC has some materials that they developed as well. So, and certainly you can be in touch with either Mary or myself, and with a specific question, and we'll try to connect you with a resource.
Great, thank you so much. I believe we've run out of time. We've left the contact information slide up on your screen, so if you want to jot down Phil McCallion's email address or Mary Hogan's, you can do that, and you also have the slides available to download on the webinar platform if you'd like to reach out with any further questions. I want to thank everyone for joining us today. This has been a great session. We really appreciate your participation. And I want to also thank, of course, Mary Hogan and Phil McCallion for your excellent presentations. Again, thank you very much.